So I'm going to get things started as people might continue to join us. So good morning, and thank you guys for joining us today for Understanding Vaccination Uptake Among People Who Inject Drugs, Exploring Influential Factors and Risk Behaviors. This presentation today will delve into an in-depth analysis of the pattern of COVID vaccination uptake among people who inject drugs. The focus will primarily revolve around understanding the multifaceted factors that significantly influence the reception and acceptance of the vaccination, emphasizing the critical importance of receiving at least 2 vaccine doses. This exploration will include a detailed assessment of risk behaviors, such as injection practices and sexual behaviors, along with various demographic characteristics. Joining us today to provide this presentation is Dr. Farzaneh Zolala, Senior Research Fellow at the Kirby Institute at the University of New South Wales. Dr. Zolala is an epidemiologist with more than 20 years of experience providing a range of clinical health services, academic research, and education and training. She previously worked at the University of Queensland and at the Kirby University of Medical Sciences in Iran, where she has held posts as Associate Professor and Director of Social Determinants of Health Research Center. Dr. Zolala has expertise working with vulnerable populations, including people who inject drugs and female sex workers. She coordinates national surveillance with people who inject drugs and related projects. Handing over to you, Doctor.
Thank you. Thank you so much. Good morning, everyone. Thank you for inviting me. It's great to be here with you. First of all, I would like to acknowledge traditional owners of the land on which I live, Turrbal and Yugra people, and pay my respect to elders past, present, and emerging. Today, we'll explore uptake of COVID-19 vaccination among people who inject drugs in the Australian Needle and Syringe Program, or ANSPS. In this presentation, I'll cover a little bit of background information, overview of COVID impacts, inequality in vaccine uptake, methodology, results, and then discussion and conclusion. Okay, let's start with a quick overview of the effect of COVID on Australia. According to the ABS, over 19,000 deaths were recorded due to COVID by July 2023. Hospitalization surpassed 270,000, and notably, COVID ranked as the 3rd leading cause of death in Australia, following ischemic heart diseases and dementia, including Alzheimer. So, as you can see from this slide, based on WHO, to stop a pandemic, it's crucial to ensure that everyone has an equal chance to get vaccinated. This means making sure vaccines are available and accepted for everyone, and that people understand the benefits of getting vaccinated. Things like how much vaccine costs, how easy they are to get, any issue with supply, what people believe, and how they view vaccines all affect whether they'll get vaccinated or not. And the last but not least is how each person behaves with regard to choose to do vaccination or not. All of these play a big role in this issue. People who inject drugs, or PWID, might be more at risk of COVID because of health problems, underlying health problems they might have, including lung and liver issues, tobacco use, and tough living situation, like unstable housing and mental health struggles. However, making sure PWID can get vaccine fairly has its own challenges. Not enough PWID get other vaccine like flu and hepatitis B. They don't go to regular healthcare much. Getting COVID-19 vaccine can be sometimes hard because of worries about being judged, stigma related to drug injection, and also sometimes it is cost. And the cost is not only for vaccine, sometimes even transportation costs can be much for someone. And the other thing is that sometimes making appointment is confusing. And the other thing is that PWID might have unstable housing, so no internet connection. Sometimes all of these contribute in making things difficult for them and make it challenge for this group to get vaccinated. And the other thing is that sometimes PWID don't trust the government, and which makes them unsure about vaccine. Okay, now let's move on to a quick introduction to Australian Needle Syringe Program Survey, or ANSPS. The Australian Needle Syringe Program Survey help keeping an eye on things for people who inject drugs. They do this by checking for infections that spread through blood and by looking at how injection and other practices might affect their health. The survey works like this. People fill out a questionnaire about themselves, and they might give a little bit of dried blood spot for testing HIV and HCV. Before COVID, around 50 places across the country did this survey with about 2,500 people each year. In 2022, 53 places joined in this survey, and we had about 1,800 people take part in this survey. In 2021 and 2022, we introduced a module related to COVID in ANSPS. This module focused on COVID testing, result of COVID testing, and also COVID vaccination details, including reason for not completing all doses. Only a small percentage, 4%, didn't answer the COVID vaccination question. So in total, we had 1,713 people answered questions related to COVID. Okay, now let's talk about our method. Actually, like similar to many studies, we needed to first of all define what variable we are going to measure and what is the outcome we are going to define. Or independent variable or predictors or variable that we wanted to measure and to know if they affect the level or the vaccination from people is demographic characteristics, key factors in injection drug use, sexual risk behavior, HCV and HIV antibody test result. And for outcome, we defined full vaccination. And by full vaccination, I mean at least 2 doses versus none or partial vaccination, which means someone who didn't get any vaccine or only got 1 vaccine. To do the analysis, we used logistic regression, univariable, and multivariable. Okay, now let's start with this table in terms of our result. If you look at this table, you see 4 columns. In the first column, there is a variable. And in this table, the first table, I provided demographic characteristics of people. In the second column, we have frequency and percentage. And in the third column, we have frequency and percentage of people who didn't do any vaccination or did only 1 doses. one dose of vaccine. In the third column, we had frequency and percentage. In the parentheses, we have percentage of people who had fully vaccination. Now, let's look at what we got here. If you look at in this table, people who are young or under 25 years, they comprised only 47 of people or 3% of our population, but these people had a higher percentage of fully vaccination, 87% compared to people who were older than 25 years, that were 75% here. In terms of gender, male had a little bit slight higher percentage of fully vaccination, 76% compared versus 73 in female. But here, if you look at sexual identity, people who identified themselves as homosexual and bisexual had higher rate of fully vaccination, 84% and 79% compared to 74% for heterosexual people. In terms of Aboriginal and Torres Strait Islanders, they had slightly smaller percentage of fully vaccination. It was 72% compared to 76% for people with no background of Aboriginal and Torres Strait Islander. And in terms of other diversity with the diversity within the population, people who spoke English at home, actually English was the main language spoken by parents, had slightly less, as you see, less fully vaccination compared to people who didn't speak English at home. If they were born in Australia, it didn't really matter, the same percentage. If you look at the second table that present key factors in injection, drug use, and vaccination status, as you see, in this table, factors related to drug use are presented. Participants who reported opioid as their last injected drug showed a higher percentage of full vaccination compared to those using performance and image enhancing drugs or PWID and methamphetamine here. Here for opioid, it is 77%, but for methamphetamine, it is 73, and PWID 74. And individual who reported ever injecting opioid showed a vaccination percentage of 76% versus 71% for here. So it means that those people who had the history of injecting opioid, and this is interesting actually, they had a higher percentage of fully vaccination. And if also look at these variable frequency injection in the last month, it shows that people who inject more often, several times a day, they had 80% full vaccination, but people who use only once a day or even 2 or 3 times a week, they had 70% full vaccination. In terms of risk behavior, injection risk behavior, such as injecting in public places or receptive sharing of syringe, the percentage were similar, not exactly the same, but a little bit more close to each other. Overdose was exactly the same, 75% for those people who reported having a history of overdose in the last 12 months and without this history. Table 3 provide information about imprisonment and OAT history. As you see from this table, imprisonment and being imprisonment or last year imprisonment, these factors didn't really play much role, at least as you see, at least the percentage are almost the same. But for OAT, if you look at these figures, you see people who reported being on OAT, yes, answer. They had higher percentage of fully vaccination, 81%, versus 72 for people who were not on OAT, sorry. This table provide information about HCV and HIV antibody and sexual risk behavior. Okay, if you look at the table, you see participant with reported HCV infection, the first actually variable, had a full vaccination rate of 78% compared to 73% without HCV infection. Additionally, individual with a positive HIV antibody had a vaccination rate of 81% versus 75% in those who tested negative for HIV here. People who were HIV positive had 81% versus people who were negative, 75%. And in terms of sexual risk behavior, having sex with other partners than regular in the last month and sex work, these factors didn't show that much difference in the percentage. As you see, they are almost similar, 75%, 73%. And now we know that the percentage of these factors were different across different factors. Now we are going to see what is the analytic view or perspective of all of these factors together. As you see from the table, let me explain the table first for you. This table provides information about univariate analysis and multivariate analysis. And the first column presents variable name. The second column presents crude odds ratio, which is a measure of association. And just a little bit of information. When OR or odds ratio is equal 1, it means that there is no statistical association between the factors we are exploring. If it is over 1, then it is positive association. It means that the more we have this factor in predictive factor, we have the more outcome. And if it is below 1, it means there is a reverse association. So, and then we have p-value. And as you know, p-value, when it is less than 0.05, it means that this association is statistically significant. And then we have confidence interval here. That is a concept that is very close to p-value. Okay, now let's go to see what's going on here. As you see from this table, in the univariate analysis, individual over 25 showed around a 60% lower likelihood or odds of fully vaccination here. You see, it is 0.43, which is 60% less odds of being fully vaccinated. However, when I put all of these variables together, in multivariable analysis, age didn't remain any significant in the model. Even here, we do not say that age is significant, we say marginal significant. It means very close to 5%. Okay. And female had 14% less odds to be fully vaccinated, but it wasn't, as you see, it wasn't significant. And for sexual identity, as you see, homosexual had a higher chance of 78% higher chance of being fully vaccinated, and bisexual had 28% of fully vaccination. And in multivariate analysis, they both were significant. In terms of Aboriginal and Torres Strait Islander people, they had about 18% less chance to be, odds, actually, the correct word would be odds of being fully vaccinated, but it wasn't statistically significant. And these two variables related to speaking other language and also born in Australia, they didn't have any effect. They didn't show any effect. And now let's look at these table. This table shows factors related to injection. We wanted to know if they have any role, statistical role. As you see, in previous tables, I showed you that opioid people who were on opioid, they were more likely that they had a more percentage of being fully vaccinated, but this percentage in the analysis didn't show any statistical significance, as you see here. And the other thing is that ever injected opioid was significant. 32% who reported ever injected opioid had higher chance of being fully vaccinated, and this was also significant. When we look at the frequency of injection last month, we see that if the person has only once a day or 2 or 3 times in a week, has a frequency of injection last month, this person, as you see, has a 41% less odds to be fully vaccinated. And this was significant in both univariate and multivariate. As it was expected, public injection, receptive sharing injection last month, and overdose were not significant, as you see. Although for receptive sharing, if people did receptive sharing, they had about 23% less odds of being fully vaccinated. But anyway, it wasn't statistically significant. And the last slide, no, not last slide of the multivariate analysis, it is about ever being in prison and also OAT. As you see, among these variables, the chance of being fully vaccinated increased if the person reported being on OAT, about 62% higher odds of being fully vaccinated, and this was highly significant in both univariable and also multivariable. And this one, the last slide of the tables, show the infection. We see that if the person has an HCV infection, reported a self-report HCV infection in past, in lifetime, they had 34% higher odds of being fully vaccinated, and it was significant in univariate, but wasn't significant in multivariable analysis. In terms of HCV antibody positive and HIV antibody positive, we see that People who were positive in HIV had a higher chance, 38% higher chance, or odds of being fully vaccinated, but it wasn't significant. In terms of high-risk sexual behavior, actually risk sexual behavior, we see that those people who were engaged had a little bit slightly less odds of being fully vaccinated, but this was not significant. Okay, so our result shows that among 1,713 ANSPS participants, 1,283 or 75% reported at least 2 doses of COVID-19 vaccination, and 430 people or 25% reported no or only one vaccination. And as you see, this result shows that among PWID, the rate of vaccination is lower than general population in Australia. The proportion of full vaccination was higher among participants under 25 years. That was 87% versus 75%, and men had slightly higher proportion of fully vaccination. That was 76% versus 73%. And in multivariable analysis, we realized that we found out that bisexual and homosexual participants were more likely to have been fully vaccinated than heterosexual participants. Participants who reported daily or more than daily injection were less likely to be fully vaccinated. Compared with those who reported less than daily. It means that people who injected more often daily. Also, people currently receiving OAT were more likely to have been fully vaccinated than those not. Okay. So, what we can find out is that still 1/4 of these people of PWID did not get COVID vaccine. And people who were engaged in somehow with a service, even if they were under any engagement with the system, such as OAT or being HIV positive and engaged with the system, might get a better chance of being vaccinated. And we learned from previous studies that was done by TOPI, we found that in a clinical trial, if the first of all, if we introduce short interval to get fully vaccinated, for example, they got 7-day interval, and then only 3 weeks. So it was 0, the day 0, 7, and 3 weeks, 21 days. And then they introduced a small amount of money as incentive. They realized the rate of vaccination, fully vaccination, really increased. So what we learned from previous studies and also our study, vaccination could be increased in PWIDs if it is introduced in harm reduction services and via outreach, and if particularly it coupled with increased support of peer-based workforce, and also introducing a small amount of financial incentives also can improve rate of uptake of vaccine COVID. And so, and also, we need to make sure that people who are not engaged with services, such as people who are not on OAT, people who have sexual identity of heterosexual, they might be need more attention to be fully vaccinated. Okay. And as I mentioned, this work was conducted at NSP Services. So I would like to acknowledge and thank all people who were involved in these surveys, including people who work as a staff or manager in NSP survey, and also NSP's National Advisory Group, lab group, and all of the people who help and the most important participants in an ANSPS survey. So all of these hard work lead to have such a enriched information about people who inject drug. And usually one of the problem related to this group is having information about the health issue they might have, and to find out the best way to help them. This study was one of the study to just know about the pattern of COVID, and these can help us in future for other pandemic to be ready and to be prepared for to be make sure that they are fully vaccinated. Now, I am happy to take any question if you have, and thank you very much for listening to this presentation. Please let me know if there is any question.
Thank you so much for that presentation and for that information. It's really valuable data that you're gathering through this needle and syringe program survey to help us better understand this cohort and kind of meet their needs around vaccination, especially with COVID now, and hopefully looking through this and, you know, as you said, hepatitis and how it applies kind of more broadly. I don't have any questions in the chat yet, but I was wondering personally kind of where you're going with this research from here. So will it be included in the next survey? Will there be kind of any further questions to kind of explore some of your findings or any other actions?
Actually, for COVID, I think because we have actually in 2021 we had another type of question, because as the pandemic just evolved over time, we learned from the behavior of people and how they react, because we had, for example, in 2021, we had the waiting list. If you remember, there was waiting period, and that waiting period played a role. And now in 2022, it wasn't the case of getting access to the vaccine. A vaccine was available for everyone, but so we learned how when the pandemic evolved over time, we learned how people behave, and it was really great and valuable information. And for next year, I am not sure if we are going to continue with COVID vaccine, but definitely this result will be communicated at the higher level, and definitely they can affect the policy in future, because they can at least inform the policymakers.
Perfect. Thank you. Just checking the chat. See any other questions as of yet? I do have one more question in my pocket. I was hoping you could speak to, of course, obviously there's a lot of vaccines that are, you know, very valuable for people who inject drugs. And of course, you know, COVID falls, I guess, more in line with the flu vaccine from what we're understanding for this vulnerable community, whereas it's not a fixed term kind of series of vaccination, and kind of people are going to need to get those booster doses likely into the future as far as we understand. I was wondering if you could speak a bit more to kind of what we can do in terms of that messaging and how that might create more barriers as this becomes kind of a long-term, more influenza style of infectious disease.
Well, actually, maybe I'm not the best person to answer this question because it goes beyond my knowledge, and someone with a proper knowledge can answer these questions. Sorry, I'm not the best person.
No, that's okay. That's okay. It's something that I've been kind of considering. I don't know if we have all the answers for it yet. So, I do have one question from Pauline Malloy. They've said, can you please explain why something can be statistically significant in a univariate analysis, but not in a multivariate
Oh,
analysis?
actually, it is a very, very good question. Thank you for asking. When we do Oh, I look at here. When we do analysis of a univariate, first of all, for example, if I put only age in the model and age become significant, I am not still sure if this significant is because of the effect of age, or could it be because of other factors that is related to age. For example, if people who are older are more likely to be female, or people who are older are more likely to be on OAT, or any other things. Then when we add them in the multivariate analysis, then because other factors contribute in the model, so the effect of each variable will be adjusted based on effect of other variable. So at the end, that we see in the multivariate analysis is more accurate because it adjusts other variables' effect on each other. I hope that helps. Is that it was it clear?
That makes it make a lot more sense to me. And thank you for explaining and kind of walking us through the data. Pauline said yes, it's clear for her as well. So
Good, thank you.
I'll give one more minute to see if there's any other questions. Otherwise, we might wrap up a little early. And I just want to say, I really appreciate your kind of style of presentation of walking us through the data and showing us how to kind of read those tables and such. I think, obviously gathering all these surveys and such is important, but the whole understanding what they say and understanding that, what they say is, statistically significant as you kind of walked us through is really vital to the work that we're doing. So thank you for that.
No worries. Thank you. It was great really to be with you, and it was my pleasure to present these results for you.
So I don't have any more questions at this point. So I'll wrap things up and I'll close with noting that this webinar has been recorded and this recording will be available to attendees and others via VADA's YouTube page and website in the coming weeks. So keep an eye out for that. And if you ever have any further questions thereafter, feel free to reach out and I can always put you in contact. So thank you guys and have a lovely rest of your day.
Thank you.